you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com about, or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
Now this way I can see your award back there, and see that white one?
Yes.
That is called the Whiteboard Award.
Ooh.
That was, I think the language on it is it was at the 10-year anniversary, and it was for the people who hung in there for the first 10 years that when the core was really bad. And they hung in there anyway, and they came all the time. This one, I found at Georgia's because I don't know that I ever got one. So that was pretty fun.
Hanging in there, I feel like I've been like surfing the wave and not like hanging in there. Like I feel like I've just been riding this unbelievable wave of knowledge and change and improvement and new ways of thinking. So like hanging in to me seems like torturous almost, but I'm very grateful that I joined the wave when I did.
Well, and it has improved and changed so much in the last, especially the last 10 years, but the last 5 years, where the focus shifted to how to think.
Yeah.
And I did that this week.
Yes.
There was a patient this week. He came in on Monday, and he had circles on his low back, in his neck, and he had an auto accident, and he had headaches all the time, and he had neck pain, he had left shoulder pain.
And by circles, you mean just he circled it on his history?
Yeah, on his little pain diagram.
Not physical.
Oh, yeah, no. And then he said, oh, yeah, by the way, my left thigh is numb. And I went, oh, okay, well, that's easy. He said, no, it's been numb for 20 years. And I said, well, it's still not that hard. It's the lateral femoral cutaneous nerve. And he said, what? So I said, here, let me show you. So we used the pinwheel, and I used the little ink pen, and I made the circle, and I see, and I showed him the diagram. That's the lateral femoral cutaneous nerve, and there it is, it's numb. And I said, how did it get numb? He said, I don't know. I said, well, it doesn't matter. Should be okay. So went from his low back. So we had low back pain and hip pain and then neck and shoulder pain. And I had him for 4 days. And I said, there's no point in fixing your neck first because that's like going to be easy. And he looked at me like I was green. And so let's just do low back first and this nerve. So we treated the nerve. And then the low back was, I thought maybe facets, but put my hands in, and he's a farmer, or he was a farmer. And I said, do you ever fall flat on your back? And he looked at me like I was green. Like, of course I fell on my back. What are you talking about? So I started working on his psoas, and we had this one unit that was just running from his low back to his knee to the end of the lateral femoral cutaneous nerve. And I put my fingers in his psoas, and he said, ow, that's in the front. And I said, yeah, that's what's causing your low back pain. And even if it's a disc in the low back, it won't do any good to treat the discs or the facets unless we fix this muscle first. So did the psoas, did the other psoas, then traced the edge. So took about an hour, traced the edge of the lateral femoral cutaneous nerve. And sure enough, we had it about an inch narrower and an inch shorter where it was numb. And then the next day he came in, and it had continued to improve night. So there was just a little circle. So we put it at the end of the circle, and we ran 40 and 396 and 81 and 396. So reduce the inflammation, then increase secretions. And I said, how's your low back? He said, it doesn't hurt. I said, oh, goody. Then we don't have anything else to do. All I have to do is your neck. Oh, you have to do is my neck. So we did scarring in the dura, and then I just did the supine cervical practicum, like literally. That was it. And at the end of it, I used my little activator at C1, C2, C3. I explained about the jelly donut at his lower part of his neck that made his shoulders hurt. And he got up and no neck pain, no low back pain. He said, well, what are we going to work on Thursday? And I said, I don't know. It depends on what shows up. Mm-hmm. I said, but for today, your job is to learn how to sit. He said, you were going to give me some exercises. And I said, well, your exercise for today is to sit. And he looked at me like I was green. And I said, so to make your neck stay better, now that you can do this, you sit so that your weight is just behind your testicles on those little bones back there, and you roll your pelvis forward and you stick your belly out and look at my ears when I do that. And he looked and he said, huh? I said, here, watch this. So this is the way you sit. And he said, yeah, that's the way everybody sits. I said, everybody with neck pain.
Right.
And I said, now watch my ears. He said, yeah, they're about 2 inches in front of your shoulders. I said, now watch what happens. When you put your feet back, you drop your knees and you stick your belly out. He said, oh, your ears are over your shoulders. I said, that is the point. And then drop your chin, because all of his headache pain was coming from the 2-3 facet. So you just drop your chin, stick your belly out, drop your chin. I wrote it on a piece of paper.
Yeah.
I left the part about the testicles out.
Yeah.
Stick your belly out, drop your chin. Because out of habit, he'd stick his belly out and he still raised his chin. I said, no, drop your chin. I said, you do that between now and Thursday, and then we'll see what's left on Thursday. And that was sequencing that I wouldn't have thought of 20 years ago. I would have treated lumbar facets, and I would have done this and that. And it's like, you had to do the psoas before you could get him to roll his belly out and get his ears over his shoulders and drop his chin. And you had to do this. And I only did the lateral femoral cutaneous nerve because you could prove with the little ink marks that you could do that. And that was like Harry Potter stuff to a non-FSM patient. That's like, how'd you do that? It's nerve pain's really easy. We can do that. So that was yesterday.
Well, we have a lot to, my favorite thing, unpack what you said, because I'm writing little notes of all of the story as you're going through it, because there's really important pieces that I want to highlight for the practitioners and also for the patients. Low back pain is arguably probably the number one complaint in America, next to maybe headaches, as far as like MSK pain goes, right? Neck pain, low back pain, headaches, super common complaint, but can have a very complicated set of treatments that don't always work. And depending on who you see, you can get ushered down that road of pain meds and injections and
problem.
Yeah, like just never really fixing the root cause. And I don't know if that's because these people don't have tools to fix it, or that's just, what's the saying, if all you have is a hammer, everything is a nail. So if all you can do is write a prescription, that's probably where you're going to target. My own primary care provider is guilty of that as well. And she's like, I know you don't want the drugs, but I'm like, I don't want the drugs. I want to fix my hip, which I did fix, by the way. We can talk about that on a whole other podcast. My hip's fine.
Oh.
It just took a while. But the point of...
this makes me want to get my hands on your hip, right?
Yeah, and you're just going to have to wait till we see each other, because you don't believe me, but so far it's behaving right now.
Okay, it's behaving. I like that.
Behaving is good. So, when you're talking about the history, mechanism of injury is a big one, no matter if it's a a layperson, an athlete, chronic pain, we want to gather as much history as possible. Now, you had made a point of when I think it was you were talking about the numbness, like what caused the numbness or when did it happen? You're like, it doesn't matter. Now, some of us get really caught up in, well, how did it go numb and when did it go numb? And for that moment, though, it doesn't matter because you've got frequencies in your tool belt to help you with numbness. And we talked about, or you talked about 40, 396, inflammation of the nerve, 81, 396, increased secretion of the nerve. Those two combinations work extraordinarily well for nerve pain. And I think that's why we say nerve pain is easy and then expect to get struck by lightning, because to anybody else, nerve pain is extremely difficult.
And he had no reason that he should have
Right.
numbness, but the lateral femoral cutaneous nerve, I put my thumb where it comes out and he went, ow. Okay, well, there's a little bit of scar tissue there. We'll fix that. Maybe that's what did it. But when I looked up to show him the lateral femoral cutaneous nerve, the search on my phone said it's associated with sometimes with the inguinal ligament where it crosses, where that nerve comes out just before it comes out superficially.
Right.
And I thought, we'll treat the ligament after we treat the psoas, because the psoas is an internal rotator, which would make the inguinal ligament tight on that side. And the side where it was numb was more psoas than it was. The psoas was worse than it was on the other side. So what if, I mean, that's the question for FSM.
Right.
What if the psoas is internally rotating that left hip and causing the inguinal ligament on that side to be tighter? Right. And that's why. And he said, I worked on a farm, so I'm always falling on my back. Okay, and he had 2 auto accidents, and that was the neck. That part was easy. So the why was fairly straightforward, but he wasn't complicated from our perspective. There was no SIBO, there was no COVID, there were no COVID injections, there was no thing. There was 2 auto accidents, one in 2006, 2021, and that's it. And he worked on a farm. Oh, and I take it back. He worked on a farm, but he's a mechanical engineer. So I have hung around engineers since college. I speak engineer. I get how their brains work, so I could explain especially mechanical engineers. You could explain the mechanics of what was going on in his neck, his low back, and the psoas in engineering terms, in mechanical engineering terms. This is tight, it does that does that, and that squishes that nerve. He said, oh, well, that makes sense. And it's like, once they understand it, they stop being scared. It makes it really fun.
I think the explanation really helps patients take that anxious energy that is around a diagnosis, and especially chronic pain, just down to a level where it's digestible again. There's so many people that, and I shouldn't even say chronic pain, like depending on what the injury is, there's an energy around an injury that can make, it's palpable as a clinician. You can understand the impact that it's had on somebody's life. And frequency aside, just explaining and unpacking and saying it's not that hard, it's not that difficult. This is how we're going to approach it, laying out the plan, not over-promising, right? I tend to under-promise and over-deliver.
Exactly.
Saying, I hope to make a dent in this. I think I can make a change, but let's just see what happens. So I think that was also really important that, and I know your patient structure could be is a little bit different than for those of us who don't see it out of town or so much. So I believe you have 2 days and then 1 day off and then 2 days that you see somebody. And, even those of us who don't have that structure, you will get those questions like, well, if it feels so good, what are we going to do the next time? And are you sure I need the appointment next week? And I said, yes, because something else will probably show up. Because you've had this for a while, we are expecting changes in the chain to occur. We want to make sure that whatever benefit we have, we can piggyback on that, right? We never want to be at a deficit again.
Well, and I use the magic phrase, everything's connected to everything.
Exactly.
So when we fix this thing in your shoulder, your low back's going to be different. When we fix this thing in your low back, your neck is going to be different. I can't tell you how it's going to be different. That's what Thursday's for. And if you have no pain on Thursday, I'll send you home.
Yeah.
So I have 4 days. So he had 1, 2, 3, 4, 5, because I always run concussion in Vegas on everybody. He had 5 machines on him. And for people that only own 2 machines, that's why it's twice a week for 4 to 6 weeks. This is 6 weeks worth of work in 4 days, but only because I've done it 200,000 times. And
for the nerve pain, we're talking about 4396, 81396. I feel like
that was numbness. He had no pain.
Did you have 2 machines doing that at the same time, or was that
just one?
Yeah.
I did 40 and 396 as I was working on his right psoas with 1 machine, and then switched to his left psoas. And when I moved over to the left, I switched the left lateral femoral cutaneous nerve to 81 and 396. And I made little ink marks as it got smaller. And it was really interesting. And then I had a knee replacement I have to tell you about it because it's really fun.
Okay. We have a lot to talk about. I want to make sure as the questions are coming in that we give them time, because I feel like the last couple episodes we've been like racing through them at the end.
Oh, there.
So, I leave. We did get an early start. Okay. Let's just jump to Lisa's quickly, and then we'll talk about me, and then I want to talk about something very funny too. So Lisa has a friend whose son had a log fall on his head, fractured his skull, was in the hospital for 3 days, was always conscious. He was released a few days later, and his ears started hurting, went to the emergency room, home now. Friend is conventional. I think FSM would make a difference with his brain, of course, vagus nerve. What would you suggest I say to her to explain how FSM could help?
Well, the first thing is, what do you mean his ears started hurting? Like, where did his ears hurt?
Like, is it lobe? Is it in the ear?
Inside the ear canal? Right. Was it, because the C1, if you think about here, the log fell here and fractured his skull. Where was the skull fracture?
Right, he could have fallen this way.
Yeah, but where the skull fracture happens makes a difference.
Yeah.
And what part of his ears hurt, because if the log fell on the back of his head and jammed his head back in the process of the fracture, the ear pain, if you look at the pain diagram for C1, it comes up the back of the head and right over the top of the ears. So is it the C1, the occiput C1 to facet? Is it the vagus nerve as a pain generator? The FSM will make a world of difference. So you run concussion in Vegas, yay. You ask to see at least this is what I would do. I'll ask how you'd handle it. But first thing you ask for is the MRI of his skull. Did he bleed? Does he have a subdural hemorrhage? That at 17, the sutures are a little more flexible than they are when you're my age, your age. Yeah, there's a lot of unanswered questions here.
I think one of the greatest things that we can kind of say too is that it's safe, right? It's not going to make anything worse. And that's like, when we see concussion and head injuries in sports, everybody is so worried about making anything worse. And this can provide such great pain relief, and it's safe. So I think, for a mom, that to me, that would be one of the first things I would want to hear is,
Can't possibly make it worse. We can treat the fracture, make his head hurt less.
yeah,
We can treat the dura,
yeah,
and treat concussion in Vegas and see how he feels.
yeah,
And then with a skull fracture, you always wait. It's like, what part got fractured? Is there going to be a vestibular component in 6 weeks? Where's the pain coming from? Just
yeah,
because the skull is fractured doesn't mean that the ear pain, skull fracture and ear pain don't go together.
right.
So, yeah, good answer. I like that.
Yeah. I mean, sometimes, I have a tendency to try to over-explain everything and the mechanism of action and how this is affecting. And sometimes we just need it. And I quoted you yesterday. It was so great. I took a snippet of it. It was the first piece of advice you ever gave me before I came to lecture at the Advanced. And I had like all these slides and I was completely overwhelmed. And of course I was nervous about presenting and I had like way too much information. And you said, what you want to say has nothing to do with what they need to hear in order for them to learn what you want them to know, or something like that.
Yeah, no, it's the best training I ever went to. It was a train the trainers. It was a training for teachers. And he went on and on for 6 hours, but that was the quote that stuck with me.
And even that first part, what you want to say has nothing to do with what they need to hear.
And after that, my lectures completely changed.
Yeah.
So I wanted to show them what I knew.
Yes.
And they don't care.
No. And even if they do care, maybe they just need to hear it differently. So I think about that when I'm talking to my children, my husband, patients. We want to say certain things. And sometimes, I'll even find myself getting defensive about FSM because people will say things like, well, if it was so great, why isn't it everywhere? Why isn't it here? Why isn't it there? Why don't, and there's.
And the answer to that is we have 7,000 practitioners in 23 countries. And you have to remember that we're talking about a profession that took 50 years to learn to wash its hands. And the fact that a third of our practitioners are MDs is pretty good.
Yeah.
So we're a lot, and we're only 30 years into this. So in 20 years, we'll see where we go.
Right.
Because there's some of the things that we do with FSM where there's no turf. There's just no turf.
Yeah.
It's nerve pain. There's no turf. We run into turf with wound healing. That is a $4.1 billion industry for wound care.
Wow.
Gabapentin, whatever. It doesn't work. I mean, anyway. So the nerve pain, diabetic foot pain, doesn't work very well, makes them goofy. But it's the wound care, because once you get a neuropathy, then you'll get a diabetic wound, and then there's turf.
Yeah.
And then, so I haven't been able to get anybody to do a control trial or to even add FSM to conventional treatment. You can go ahead and make your $4.1 billion on wound care, but let's see if we can speed it up. Well, if you speed it up, if you double it, the head of the wound care department, because I've done this at 3 different wound care facilities, the head of the wound care department, if we double it, they see their revenue going from $4 billion to $2 billion. And it's like, okay, so that's not going to happen. Let's stick to the places where there's no turf. And that's neck pain, low back pain. This guy's had low back pain and neck pain for 20 years. It's like, okay.
One of my favorite things is to make other modalities and other clinicians look good. It's not about turf wars or taking or proprietary information. It's about sharing and collaborating. And that is where I feel true healthcare gets results, is when there is a team behind the individual and the individual's health and recovery. And if we can all work together to speed that up, I mean, that's how everybody wins.
Yeah, it was fun. Knee replacement.
Okay.
After you.
No, I will follow up after the knee replacement.
Seriously?
Yep.
You're so good.
I am feeling very kind and generous today. You got me on
You really are.
glorious Wednesday. Yes.
Okay. So most of the time, knee replacements, the problem is knee flexion. Well, this guy had FSM 4 hours after the knee replacement and FSM for 6 weeks. And so his knee flexion is 120 degrees. Yay.
Yeah.
He can't straighten it. They can't get it flat. He was 5-10 degrees flexed, couldn't get his knee flat.
Yeah.
So we laid him on his back, and his daughter, or the girl that I've been treating for 30 years, who's like his daughter, brought him in, and we laid him on his back. And she said what they want him to do is put a weight on his knee and just stretch those tight tendons. And she said, I think it's just scar tissue. And I went, okay. So we opened Netter to the hamstring. So when you felt the back of his leg, the medial hamstrings were like guitar strings almost to his ischial tuberosity. It was so hard and tight. It's like, well, that would explain why he can't straighten it. And she said, well, it's got to be scar tissue. And it's like, I don't think so. So when you look at the mechanism of how they do a knee replacement, it's pretty brutal. You cut the femur here, you take the top off the tibia, and then you do that to everything. And then you put a pin in titanium, he thinks, into the tibia, and then you put a little cup on the top of the tibia, and then you jam another pin into the femur that's got the roundy part for the femoral condyles that fit into the top of the tibia. Well, what happens the only thing they cut is the quadriceps tendon. They cut that, they leave your own kneecap, they just fold that back. Then when they're done with the carpentry, they move the patella back where it belongs, and they reattach the quadriceps tendon to the tibia, to the front of the tibia. So what gets traumatized to make enough room for two guys that look like linebackers? If you look at orthopedic surgeons, they're big guys. And what gets traumatized? The tendons. So she said, it's got to be scar tissue. And it's like, I don't think so. So I ran torn and broken in the round tendons because, you look at the hamstring down by the knee, didn't do it. And then I looked at Netter because the medial part of the most medial part of the medial hamstring attaches to the femur with connective tissue. So I had one machine that ran from his low back to below his knee with just 124 and 77. And I treated him for an hour and a half, almost 2 hours. And 124 and 77 ran the whole time. And so this started to soften. And then I had a second machine that was on 124, torn and broken, repair the round tendon for the distal part of the medial hamstring. The lateral hamstring, I've now got torn and broken in the connective tissue, torn and broken in the round tendon, and then third machine from his low back to below his knee for scarring in the nerve. And And we just, as everything softened, Tracy has been a patient for 30 years, and they've both taken the core twice. They've been to the advanced once, and she has a blue box that just died. They have several custom cares. And so we started playing with, here, feel it soften, and then move it. And as you started to treat the scar tissue in the nerve, then the hamstring would let go a little bit. So that answers the question, if you were the cerebellum and the hamstring or the tibial nerves were glued, because think of what happens when they do this to the knee, what happens to the tibial nerves as they come off the hamstring, right?
Mm-hmm.
So we ran scarring in the nerve, and I heard your voice in my ear, trauma to the muscle. It was because it was a part of the hamstring that wouldn't let go. And it's like, there was Kim in my ear saying 294 and 46, the muscle. And that helped. And then it was 124 because they tore the sarcomeres. In the process of stretching the tendon, you create little tears in the muscle. So he's laying on his back, and his knee keeps sinking closer and closer to the tabletop. Sclerosis in the fat pad, because remember the fat pad behind or around the nerves. And then it still wasn't done. It was still tighter than it should have been. And I know it was, he said he thought it was titanium, but he wasn't sure. But almost everybody uses titanium now. So I did metallic toxin in the bone marrow. And then he did because it's been 8 weeks, did scarring in the bone marrow and started to just rotate the femur, internally rotate the femur, externally rotate the tibia, basically fixed it so the knee has normal internal and external rotation. And the muscles went, oh, thank you.
Yes.
And that was it.
And that sigh of relief that you can feel of when, and no, muscles can't talk, but if they could, that is exactly what they would say. You can feel that localized relief. You can see it on the patient's face. There is all of that happening.
It was really fun.
I have something. So I had something fun to share. And I want to share it as we kind of unpack the knee replacement. So I work with a lot of law enforcement officers, and we were talking about crime scenes the other day. And I said, I look at a new patient and as an appointment like a crime scene. And he's like, ooh, let's talk about this for a second.
That's a great idea.
So there are 7 S's of crime scene investigation.
7 S's?
Letter S. So this is how I got through college, was with acronyms and abbreviations and all these other things. So I want to see these for the practitioners. And I also want to say these for like the patients. So when you see an FSM practitioner taking their time unpacking a story, this may or may not be helpful, but for someone's brain like mine, I think it's just very interesting because I think a lot of us do these S's automatically. So the first S is securing. So obviously a police officer would secure the scene, but our jobs, I always want to make that patient feel safe and secure in the treatment room so they can tell me their history and all their history and the nuggets they don't want to share and have never shared, because as we know, the more information we get, the mystery is usually in the history. So securing is the first S. The second S is separating. This is when they separate, different parts of the crime scene and they get forensics and they get other people to blood spatter.
Well, they separate the witnesses so the witnesses can't share their stories with each other.
Yes, that is the actual other part. So when we talk about separating, I was thinking about when we do have those stories of, if the partner's in the room or sometimes, it's good to have somebody in the room to fill in the gaps, but sometimes we need to separate the witnesses or separate people so we can get them individually. You talked about when there's history of sexual abuse, maybe we're not getting that part of the story if somebody else is in the room. I also think of separating as getting all the separate pieces of information, the MRIs, the X-rays, the stories from the other practitioners. So that's our second S. The third S is scanning. Obviously, we do this. We're doing our own physical exam and all the different ways that we do a physical exam. So that's scanning. Then we have seeing. Obviously, we are seeing with our eyes what's happening, but we also talk about putting our eyeballs on our fingertips. So sometimes we see more information when we start palpating. Do you want to elaborate on, you were doing this? So I think there's something that you have to add to this.
Well, that phrase that we use in the core, put your brain at the end of your fingers, put your eyes at the end of your fingers.
Yeah.
When I felt his medial hamstring, didn't make sense. It's like it makes sense for it to be tight down with a round and flat tendons attached, but to be tight halfway to his glutes,
Yeah.
that something's not right. And my fingers are what saw that. What the physical therapist saw was 5 degrees short of fully extended.
Yeah.
And my fingers saw this hamstring's not right.
Yeah.
And the back of the knee is not right.
Yeah.
What's at the back of the knee? What's at the medial hamstring? What's up halfway up the thigh?
Yeah.
It's
Yeah.
see with your fingers.
Exactly.
I love it.
And there's more. Then we have sketching. When I think of sketching, I think of netters. So it's seeing with your eyes and then being like what you just said, what is that? And sometimes getting out some anatomy books can be very helpful because we're re-seeing, we're relearning, we're seeing anatomy in a completely different way with FSM because it's not just a muscle we have to squish. It is being more respectful to the structures that are around there, getting more ideas, which leads me to the other S. The next one is searching. So we are seeing, we get our sketch out, and now we are searching for the adhesion, the area of contracture, the congestion, the searching for the cause. We're thinking, how did it get like this? And then
I got to back up a second for sketching because I watch crime shows and I read mystery novels.
Yes.
When a police officer, when a team sketches, there's one guy that photographs it.
Yeah.
There's another guy that sketches it.
Yeah.
And part of sketching is to take measurements and it actually includes more than the outline of the body on the floor.
Yeah.
Where's the couch? Where's the pillows? Where's the chair? Where's the blood? Where's the blood spatter? Are the blood drops round or are they oval shaped? Does that mean he walked from here to there? Are the blood drops? So all of that is included in the sketching.
Yeah.
So sketching is, yes, you get netter out, but it's also, I guess, getting a picture in your head of all of the parts. So, for example, with this guy with the low back and the psoas, there was absolutely no point in treating his neck on day one. Until his psoas was longer, he couldn't sit the way he needed to sit to keep his neck fixed. So that's the sketching too, is seeing how all where the pieces are, how they all fit together.
Yes.
Great S.
Sketching. Then we said searching, right? Searching for how they fit together. What else could be there that you missed? Because now you have the sketch or the schematic, even to the plan to look at. And then the last S is the same as the first S. It's securing and collecting evidence. And I love this because we are securing now what we have maybe taken apart. We're creating that 4089 environment where it's safe to move. Securing movement, securing safety, securing the fact that change has occurred and that change is okay. But the big piece that I like at the end is collecting evidence. And now we have to chart and we have to re-examine and we have to test range of motion because that is our evidence that those are our objective findings that showed that our treatment worked.
The little ink marks where lateral femoral cutaneous nerve goes from this big to that big.
Yes.
That's great.
Those are our 7 S's for crime scene / FSM.
What a great way to look at it.
Yeah, I thought it was fantastic. Securing, separating, scanning, seeing, sketching, searching, and then securing and collecting evidence. It sounds overwhelming, but I think if we, and for maybe not everybody's brains appreciates those steps, I've always appreciated some sort of recipe or guideline to follow. And then within those guidelines, I want freedom to explore and go rogue. But I think having some sort of plan to follow can be very helpful.
Oh yeah. No, it's and seeing it as part of a whole. So it's the crime scene is not just the dead body on the floor,
right,
or the open safe and the missing jewelry. It's how they get in.
Right.
Is the window in the back door broken? Is the lock picked?
Right.
How did they know the combination to the front door?
Right.
How did they get into the safe? Where are the fingerprints?
And then we go even one step further and be like, what led the person to burglarize in the first place? And then you're really solving the case, right? But it is the ability to go in so many different directions, thinking outside the box, because you get to think outside the box. That to me, that freedom of exploration for symptoms and history and creating a plan that works for everybody involved, you as a practitioner, the patient, that to me is where the magic happens. And the safety, I love that. That is my Kim Safety Pittis. Like that is my middle name. I love to create safety. I want the person to feel safe in my presence with the treatment, and I want the body to feel safe to move. That is utopia.
And the other part of, I mean, I love watching mystery shows, but the other part of it is that there is a team that does this. Yeah. The guy that does the sketches is not the guy that takes the pictures, is not the forensic person that analyzes the blood spots. It's not the medical examiner that looks at the dead body. It's not the guy that does the fingerprint. It's a team. So last week when we weren't here, there was a lady that came from across the country someplace, and she had medically induced iatrogenic, it would have been Parkinson's, but it wasn't Parkinson's. She had no tremor. She had rigidity. She had cogwheel in the hand. And when you heard her history, it started out with an addiction to Ativan that was created by an MD who told her it was not addictive.
Do you want to explain what Ativan is to lay people listening?
It's a very addictive anti-anxiety drug. She had a situation that created anxiety, and his first leap was Ativan, which is like the third drug you use. And she's very naturally oriented. She'd rather do everything with supplements. So I look at her list of supplements and it's like, okay, she's taking everything I would have suggested plus 8 more things that I wouldn't have even thought of, but that makes sense. And then she had a brain scan from the Amen Clinic, and she had an MRI. And basically the caudate nucleus, which I had to look up what it does, the putamen, which I had to look up what it does, and then the basal ganglia. And I knew what that did. None of them worked. Oh. In the Amen SPECT scan, that's a whole nother conversation. You never take one of those at face value, but there were little red spots there, and those, man, the red spots mean they don't work. And then the MRI without contrast, but it was a special kind of MRI, like a functional MRI. Mm-hmm. And once again, 34% reduction in the function of the caudate nucleus. And I had to look up what that did. And then the putamen and the basal ganglia were all 34% down, 41% down, 20% down. It's like, whoa, the whole dopamine pathway was trashed. So when she was addicted to Ativan, she went someplace to get unaddicted. And their solution was to give her Zyprexa, which is an antipsychotic. And those work on the dopamine pathways. And the number one side effect, at least the worst side effect, is tardive dyskinesia, which is everyone I've ever seen is like uncontrollable athetoid movements. That wasn't her. Hers was the Zyprexa just trashed the entire dopamine system.
Wow.
And I said, well, I'm not going to treat you today. Like, she and her husband had come clear across country, and she absolutely believed that I could help her. And I said, I probably can. I can't make you worse, but I have to make sure that it's safe. And I got to talk to the dopamine guy. So I talked that night, talked to Patrick Wood, the dopamine guy. That's his area of expertise. And I said, okay, what does Zyprexa do to her brain? And he said, well, it trashed the whole dopamine pathway. It just burned it out. And that's what's wrong. It's like, does she have a tremor? No. Really? So she doesn't have Parkinson's, but she can't move. She's stiff. She trips. Her legs are really stiff. Okay, what do I do? She's already on levodopa carbidopa, which is more dopamine.
Okay.
But that actually, it provides dopamine. And even in Parkinson's, if all you do is levodopa carbidopa, makes the symptoms better, but it makes the disease progress faster. Does that make sense?
Yeah.
It's kind of like you just push it too hard. And he said, okay. So I knew about dopamine agonists, and that's what I expected from Dr. Wood. Well, I used Miraprex and he said, but you might want to use baclofen first, because baclofen works on GABA B production in the spinal cord to reduce spasticity. I'm on baclofen for the SPS because I have antibodies to GABA B receptors. So we figured out that plan. Then she came in the next day. And what I told her was, I have to make sure it's safe to treat you. So that's the secure part. And your voice in my ear. I have to make sure it's safe to treat you. I can fix this stuff, but I don't want to just throw something at it to fix symptoms. We have to have a plan.
Yeah.
So she was already taking lots of GABA. So I ran trauma I just did the basal ganglia. I left the putamen and I left the caudate nucleus alone. And I just ran trauma, necrosis, dead. The Zyprexa killed it dead.
Yeah.
So trauma, necrosis in the basal ganglia, and then 81 and 10 from neck to feet. She had just taken levodopa carbidopa when like 4 or 5 hours before. It wears off at 6 hours. And as she walked in, her legs were really stiff, cogwheel spasticity in her wrists. And we started at 10 minutes to 4. And 10 minutes after 4, I said, something's not right. You need levodopa carbidopa. Let's take a dose of what you're used to, because this isn't you need your medication. So
Yeah.
she took her meds, and I had one machine, 81 and 10, neck to feet, because I know that increases GABA.
Yeah.
B has to be. And then we ran increased secretions in the basal ganglia on one machine, and then all of the poor baby, let's fix you to the basal ganglia on another machine. And 60 minutes later, her left hand, she could open her fingers. They weren't spastic. She could close my fingers. So there's the proof of concept.
Yep.
And this wasn't cogwheel anymore.
Wow.
On the other hand,
Collected your evidence.
yeah, collect the evidence.
Yeah.
Is
Yeah.
it working? And then after an hour, it's like, okay, let's take it for a test drive.
Yeah.
She gets up off the table and walks across the room, heel toe, no stiffness, swinging her arms, a little sway in her hips. And it's like, oh my God. But she had a list. Baclofen. After you've been on the baclofen for a period of time, and if that stops working, you leave the levodopa carbidopa where it is. Don't increase that, and add amantadine or Mirapex, one of those two. So I took the advice from the other person at the crime scene, and I got an email from her yesterday or the day before, and she said, the baclofen is working like a dream. She bought 2 custom cares because she had to be able to run. I said, how long will you sit and run this? 1 hour or 2 hours? And she said, 1 hour. And I said, okay, then you need 2 units. And they could afford it. And her husband said, we're getting 2 units. So one was 81 and 10, and one was the basal ganglia. And it was the combination of FSM plus the meds she's on, plus the plan, plus using somebody that's an expert in things I'm not an expert at. Now I have, how there's this honeycomb of information that you stick stuff in.
Yeah. I love that analogy so much.
So now I have some more things to stick in the honeycomb. Amantadine, Mirapex, don't increase the levodopa carbidopa, and Zyprexa is bad. It's antipsychotics damage the dopamine pathways, and tardive dyskinesia doesn't always look the same. That was a surprise.
Yeah.
And we can help.
Yeah.
Might help.
We have an interesting question before we wrap up. Can I assist someone with getting deeper into meditation by calming the midbrain or another part of the brain, either during treatment or right after? Super funny that you say that, because I have somebody that loves to meditate and has a custom care and just uses concussion and vagus before meditation and really feels that they are meditating, going into that beautiful state, easier, staying in there deeper and longer, having more awareness during meditation, but just runs it before they meditate. I don't think he runs it during, but maybe you have a different.
No, I would go with that. Go before, and depending on, so I have the standard concussion and vagus that everybody gets based on the average amount of trauma that somebody experiences in their life.
Yeah.
But you can also tweak it for somebody that's had a lot of trauma. Instead of 40 and 89, quiet the midbrain running for 4 minutes, somebody that's had a lot of childhood trauma, you run 40 and 89 for 8 minutes, 12 minutes. I always do it in multiples of 4 for some reason. So 12 minutes, even 20 minutes.
Yeah.
And then that quiets the midbrain. the medulla, quiet the medulla. That's usually about 4 minutes. That's okay.
Yeah.
But then increased secretions in the vagus is messaging from the vagus back to the brain. So the midbrain has the ability to turn the vagus down, but the message from the vagus back to the brain, 80% of vagal fibers, and 80% of the information that the brain, that's it better, 80% of the information that the brain gets from the body comes from the vagus.
Right.
So after you run quiet the midbrain, you can increase secretions in the vagus without any risk that I know about for 10, 15 minutes. It won't take the heart rate too low. 10, 15 minutes. And then the vagus will tell the midbrain, oh yeah, everything's fine down here. The body's safe. You can take a break.
Yeah.
So the stress centers in the brain just calm down, and so you can play them, balance them together. That should make meditation easier.
And I think that summarizes why it works so well, is because, again, we talk about safety. There's no way you're going to be able to, if you've had trauma or you're in that hypervigilant mode, you're not going to turn anything off and relax. So Derek just asked about increasing secretions in pineal.
Derek, that's a good question. The pineal increases, what's the one that makes you sleep?
Melatonin. No, not
Melatonin.
Melatonin.
Yeah.
Jeez.
Yeah.
Well, it's 4 o'clock. That's why my brain's not working.
I know. There's this timer in the head. Thank you, Lisa. The thing with increasing secretions in the vagus is it increases serotonin, which helps you dream. Melatonin helps you go to sleep.
Yeah.
So if you think about meditation and what it is, it's relaxing the stress centers. That's 40 and 89. Then you turn on the vagus and it tells the brain everything's okay, but it increases serotonin. Meditation is a dreamlike state.
Mm-hmm.
And that's serotonin. Serotonin is what helps your brain dream. So you're on the right track, but I'm not sure I'd want to increase melatonin.
Can play with that tonight as they go to sleep. You can listen to this podcast and then run Concussion in Vegas and let us know how you do. But that's it for today.
It's
already.
Well, it's so good to see you.
Yes. And we'll be here next week and we'll unpack more of our 7 crime scene S's and tell more stories, because I have a great story to tell, but I'll wait till next week. You'll just have to come back and hear my story then.
Next week, there will be duct tape over my mouth, so we let you talk first.
No, we ride that wave. We just do what we need to do, and it always works out. So thank you, everybody, for coming, and we'll see everybody here, same time, same place, next Wednesday.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.